Hi friends, in this video we're going to be having a discussion about the most important images pertaining to the respiratory system. Let's get started. So the very first important image that I have shown you over here happens to be a representation at the level of the alveolar wall, wherein I wish to show you the importance of the type 1 pneumocyte and the type 2 pneumocytes. Recall from our discussion in the main videos that when we talk about the type 1 and the type 2 pneumocytes, the type 2 pneumocytes are going to be more in number. However, when we talk about the surface area being covered, it is a type 1 pneumocytes which are responsible for coverage of almost 95% of surface area at the level of the alveolar wall. We also need to understand the fact that the type 2 pneumocytes are going to be responsible for having a dual function. Fact number 1, they are responsible for secretion of surfactant, which is responsible for reduction of the surface tension at the level of the alveoli. And function number 2 of the type 2 pneumocyte is, it is going to be very important for the reparative function. So any kind of a damage at the level of the type 1 pneumocyte is going to get replaced eventually by the type 2 pneumocyte. With that basic background, we start on the discussion of the important pathological images. The first important example of an image that I wanted to show you happens to be an example of an image which is showing you the formation of a hyaline membrane. And when I talk about hyaline membrane, that's an example of that pink membrane that you have over here, which is going to be surrounding the presence of the alveolar structures. Now this is something which is very much characteristic of the development of a disease that is given the name of adult respiratory distress syndrome. Recall from our discussion in the main video section that the initiating event over here happens to be etiological factor which is responsible for causing the development of endothelial cell injury. This endothelial cell injury is then responsible for secretion of cytokines, and that is going to be responsible for the release of fibrogenic molecules, which is further going to be responsible for the formation of the hyaline membrane. The hyaline membrane is going to be associated with a presence of a diffuse damage at the level of the alveolar membrane. Therefore, the diffuse alveolar damage is going to be the hallmark feature. I repeat that it's a hallmark feature that you would associate with the development of ARDS. What you also need to understand over here is that because of the formation of this kind of a membrane, the gaseous exchange cannot take place properly, and therefore ARDS is going to be given the name of an example of a condition which is refractory to oxygen administration. Please also be familiar with the fact that ARDS is associated with the presence of a non-cardiogenic pulmonary edema. So we can be using one of the important differentiating tools between the edema that we have in this condition vis-a-vis the cardiogenic edema, which is going to be the presence of the pulmonary capillary wedge pressure. I hope most of you have seen the videos by Dr. Deepak Marwa to have a better understanding of this fact. We also can recall some of the important etiological factors which are associated with development of ARDS, and that would be associated with something like the presence of pneumonia, the presence of infections, inhalation of toxic gases, for that matter inhalation exposure to certain kinds of fumes as well. A radiological important examination finding that they typically talk about in the exam is that these patients are going to be having a diffuse damage. Therefore, the X-ray of these patients is going to be having a characteristic appearance that is going to be given the name of the white out lung. So that is the other important thing that we need to have an idea so far as the adult respiratory distress syndrome is concerned. Management of these patients primarily would depend upon the management of the etiological factor which started the whole event. So that is what we need to have an idea so far as ARDS is concerned. Looking at the next important image, over here you find the presence of a big necrotic cavity so far as the lungs is concerned, and that would be associated with development of what is being given the name of a pulmonary abscess or a lung abscess. Now one of the most common reasons for development of a lung abscess happens to be aspiration of a foreign body. Typically the foreign body that is going to be responsible for causing the lung abscess happens to be, in case of adults, the food particles. Of course, you can be having ingestion of a foreign body like a peanut or a coin in context of the children. Now, because of the ingestion of the foreign body, there is going to be a mixed floral infection which is going to be responsible for the formation of a necrotic material. As and when this necrotic material has in contact with the airway, all that pus and the necrotic material comes out, leaving you the presence of a cavity like lesion over here. This condition is also can be importantly associated with certain types of organisms in isolation. Say for example, apart from the mixed flora, which is the commonest cause, we can talk about the development of a lung abscess in association with Staphylococcus aureus. When we talk about the radiological finding of these patients, this is going to be associated with a classical finding which I want you to appreciate on the X-ray over here. There is presence of the air over here and there is presence of the fluid because of the necrotic material. So this is what is going to be given the name of the air fluid level. And that's a classical finding that you would associate in a patient who is going to be suffering from lung abscess. Talking about the example of a disorders that we discussed in detail in the category of obstructive lung disorders, I would like to draw your attention to the fact that obstructive lung disorders are going to be diagnosed usually on the basis of the simple investigation that we talk about in physiology, which is going to be given the name of spirometry. This is an example of a group of disorders which is going to be characterized by the fact that the FEV1 upon FVC ratio is going to be highly reduced because of the presence of some kind of an obstruction. The very first example of an obstructive lung disorder that I am presenting over here to you happens to be a condition which is going to be given the name of emphysema. Now recall from our discussion that the part of the lung affected in a patient having emphysema happens to be acinus. Why do we need to talk about acinus? Acinus is going to be the functional unit of the lung. By that, what I mean is that the actual gaseous exchange is going to take place at the level of the acinus. So far as emphysema is concerned, most of you are very well familiar with the protease anti-protease theory, which is going to be associated with the fact that there is going to be increase in the elastase activity responsible for causing development of emphysema. So emphysema caused because of enhanced elastase activity. To prevent the damage caused by the elastase enzyme, we do have the presence of the anti-elastase molecules like alpha-1 antitrypsin and alpha-2 macroglobulin present in the plasma. So far as the clinical significance of emphysema is concerned, out of the various subtypes, two types of emphysemas are going to be clinically symptomatic. One, the commonest type of emphysema that is seen clinically is going to be given the name of centri acinar emphysema. Recall from our discussion in the main video, this is going to be associated with cigarette smoking as the most important risk factor. It typically causes involvement of upper lobes of the lung, and by the name you get a hint that there is involvement of the proximal part of the acinus. In complete contrast, when we talk about the pan-acinar emphysema, the pan-acinar emphysema is going to be clinically very much symptomatic. However, this being an example of an enzyme deficiency, it is autosomal recessive in nature, alpha-1 antitrypsin deficiency, and this condition is going to cause mainly the involvement of base of the lung. Please be familiar with the fact that when we talk about pan-acinar emphysema, patients have been reported to be having the development of hepatic manifestations in the form of a micronodular cirrhosis apart from the pulmonary manifestations of emphysema. Of course, when we talk about distal acinar emphysema, which is associated with cigarette smokers, that might as well be associated with development of spontaneous pneumothorax. Now looking at the important finding over here, emphysema over here is going to be characterized by the important abnormal dilatation because of airway trapping phenomena that we associate with the development of this kind of a condition. So this is what is going to be typically associated with an important finding associated with emphysema. We need to be familiar with the fact that such people are going to be having the classical hints which are given in the stem of the question, which may talk about something like the presence of a barrel chest. They may talk about or make a mention of something like a pursed lip breathing. They may talk about a term which is given the name of pink puffers. So that is what we need to be having an importance of knowing about so far as emphysema is concerned. The other important example of an obstructive lung disorder that we need to be having an idea is what is going to be given the name of chronic bronchitis. Now both emphysema and chronic bronchitis are associated very much with cigarette smoking, and therefore we need to understand the fact that both of these conditions are going to be clubbed under the heading of COPD, that is chronic obstructive pulmonary disease. The moment we are making a mention of something like chronic bronchitis, we need to understand the fact that this condition is going to be characterized by the patient having a clinical manifestation in the form of productive cough. Apart from that, there is going to be excessive mucus production in these patients, which can even be appreciated at a histological level by the presence of an increase in the value of a parameter given the name of Reed's index. Recall from our discussion in the main videos that Reed's index simply refers to, in the numerator you have got thickness of the mucus secreting layer, and in the denominator you measure the distance microscopically between the epithelium and the cartilage. So these patients have enhanced Reed index, thereby kind of giving you an indicator of the fact that there is going to be an increase in the thickness of the mucus gland layer. The moment we are talking about something like chronic bronchitis, we need to be familiar with the fact that such people are not able to maintain their oxygen saturation to near normal, and therefore you use the term blue bloaters with them. Chronic bronchitis word, in spite of having the word chronic as well as inflammatory disorder, should be associated with a simple fact that in this condition, and I repeat that, you do not have the development of secondary amyloidosis. So these patients do not have development of secondary amyloidosis. We also need to be familiar with the fact that chronic bronchitis has been associated with a very small but definitive risk of development of bronchogenic carcinoma in the future. So yes, this is an example of a pre-malignant condition, but point to be re-emphasized again that there is no association between chronic bronchitis and the development of secondary amyloidosis. For the exam image, I want you to be having an idea about the enhanced thickness of the mucus gland layer, which is going to be associated with an increase in the value of Reed's index. So far as COPD is concerned, both these conditions in the later stages can be responsible for causing development of pulmonary hypertension, And because of pulmonary hypertension, patient could be having right-sided cardiac failure, which is going to be given the name of cor pulmonale. Therefore, important for us to remember from a medicine perspective is that one of the most important things which is going to be reducing the mortality in these patients happens to be the administration of oxygen. So, by whatever means you can give oxygen to these patients, that would reduce the chances of development of pulmonary hypertension, and that is what is going to save the life of the patient. That is what we need to have an idea so far as the chronic bronchitis is concerned. Talking about the next important example of a disorder which is so very commonly observed in our country, that is going to be given the name of asthma. Recall from our discussion, one of the important histological hallmarks of asthma happens to be the presence of airway remodeling. What exactly mean by the term airway remodeling is what I have tried to depict over here in the image as well. So for the reference part, the left side happens to be the airway of a normal individual, and the right side image is representative of the airway of an individual suffering from asthma. When we talk about the term airway remodeling, we are basically going to be having the manifestations like the presence of increase in the smooth muscle thickness over here. That is one important finding. So smooth muscle hypertrophy because of increased thickness. The second fact is patients are going to be having the presence of goblet cell hyperplasia over here. The third fact that we understand is that asthma being an example of a type 1 hypersensitivity reaction, so you're going to be having an increase in the number of inflammatory cells which would be consisting predominantly of eosinophils. So smooth muscle hypertrophy, goblet cell hyperplasia and eosinophil infiltration, all of them would contribute to the development of what is given the name of airway remodeling. We need to be aware of the fact that patients having asthma at times are going to be having enhanced levels of IgE antibody as well. One of the important manifestations that we have for asthma is that this is an example of a reversible airway inflammatory disorder. A standard question in the exam that can be put up to you is with regards to the sputum finding of these patients. So these patients could be having the presence of what is going to be given the name of a cruella body. These are example of degenerated epithelial cells. We could be having the presence of these spiral structures. The spiral structures are going to be given the name of Kirschmann spirals. So airway epithelial cells which are going to be acquiring a spiral shapes, Kirschmann spirals. And we could be having the presence of structures which are going to be these needle-shaped crystal-like structures which are going to be given the name of the Charcot-Leyden crystals. So I just repeat that for your better understanding. Cruella body, Kirschmann spiral, Charcot-Leyden crystals, all of them associated with the sputum findings of a patient having asthma. One of the important markers by which you can predict the severity of asthma in an individual happens to be the value of an important protein which is going to be given the name of YKL-40. So an individual having a higher level of YKL-40 is likely to be having a much more severe variant of the disease. One of the important variants of asthma that we talk about is what is going to be given the name of intrinsic asthma, which can be seen because of exposure to 3 factors. Either there can be an exposure to cold temperature, or an individual having a history of suffering from a respiratory viral infection, or in fact even in case of sensitive individuals because of the intake of certain drugs like aspirin. I hope you remember that SAM test right from a knowledge of ENT over there. Looking at the next important image, this is going to be an example of again an obstructive lung disorder that is going to be given the name of bronchiectasis. Now bronchiectasis is usually going to be associated with an important finding that you have got abnormal permanent dilatation of the airways, so much so that the airways can actually be tracked, and as you can see that very beautifully, the airways can actually be tracked up to the surface of the lungs. So usually you would have the airways which are going to be visible only at the level of the hilum portion of the lung, but over here you find airways which are coming and can be tracked at the level of the surface. So that is what is going to be associated with bronchiectasis. Please do recall the fact that it is either because of an obstruction or because of an infection that an individual is going to be having the development of bronchiectasis. The moment we are talking about bronchiectasis, we must remind ourselves of certain predisposing factors. Say for example, for our country, dry bronchiectasis, a term that is associated with pulmonary tuberculosis. You can be having a higher risk of development of bronchiectasis with conditions like cystic fibrosis. Bronchiectasis also becomes important for the simple fact that this is an example of a condition which at times in the individual can be associated with a high risk of deposition of the amyloid protein. Please be familiar with the fact that bronchiectasis is an example of a perfectly benign condition. So in spite of having that abnormal dilatation of the airways, these individuals are not, and I repeat, not going to be at high risk for development of lung cancer. So there is no risk of cancer of the lung that you would associate with a condition like bronchiectasis. That is what you need to have an idea. Of course, there can be certain uncommon conditions but which can be seen clinically like Carter-Jenner syndrome, which are seen because of a defect at the level of the Dynein arm of the cilia, which can also be associated with development of bronchiectasis. So that is what we need to have an idea so far as this condition is concerned. Looking at the next important example of disorders, we are going to be talking about now the restrictive lung disorders. Again, one of the important features that you associate with restrictive lung disorders is the simple fact that the spirometry will tell you that there is going to be a restriction to the expansion of the lung. In some of these conditions, you can also be having the presence of abnormal dilatation of the airways, which are responsible for giving a peculiar pattern given the name of honeycomb lung, about which I discussed with you with certain conditions like the usual interstitial pneumonia or idiopathic pulmonary fibrosis histological finding in the main videos as well. So let us just have a quick recap about the important restrictive lung disorders over here. Looking at the important example of a restrictive lung disorder, this is an example of a condition which I explained you quite beautifully and in detail. What is given the name of idiopathic pulmonary fibrosis. Idiopathic pulmonary fibrosis, because of an idiopathic or unknown factor, you're going to be having a recurrent injury at the level of the alveoli. So there is going to be alveolitis, and this would be associated with release of factors like TGF-beta, which are going to be promoting the development of deposition of the fibrous tissue. So the same condition as explained to you is also given the name of cryptogenic alveolitis, is what is going to be given the name insofar as the European countries is concerned. Now, the important risk factors can be including age, because most of these people are going to be having an age more than 50 years. This could be associated with the presence of certain types of genes which are going to be something like the TERT gene, and there can be some type of genes which can be having an altered activity of mucin. Now, the classical histological finding, and that is what is to be kept in mind. The classical histological finding that you associate with idiopathic pulmonary fibrosis happens to be the usual interstitial pneumonia. If you can just make out over here, the simple fact I want to highlight over here is the fact, friends, that patients are going to be having the presence of patchy fibrosis. So, the characteristic finding that you have over here is patchy interstitial fibrosis. In fact, if you can appreciate it over here in the slide as well, the patients are going to be having these acellular areas which are going to be associated with the deposition of the fibrous tissue. The same can be appreciated over here as well. So, this patchy interstitial fibrosis is what is going to be the actual important feature associated with the usual interstitial pneumonia. So, initially the patient could be having the presence of fibroblastic foci as I explained you. Subsequently, there can be the presence of the fibrotic areas, and usually this is going to be something which is going to be present quite near to the pleural surface. So, subpleural area which is going to be having the patchy interstitial fibrosis, that would explain the fact why you're going to be having the presence of those irregular dilatations, and that is what is a characteristic feature associated with the idiopathic pulmonary fibrosis. This is an example of a condition which is characterized by fibrosis. So, we do not have a definitive treatment except for lung transplantation. Of course, you do have an important pharmacology link over there that antifibrotic agents like pirfenidone have been approved for the management of these patients pharmacologically. Talking about the next important example of a condition which the examiners did ask you relatively recently, it is called by the name of cryptogenic organizing pneumonia. As and when we make a mention of the cryptogenic organizing pneumonia, all I want you to understand over here is that there is going to be a certain connection or balls of connective tissue which are going to be present at the level of the alveoli, the one which I am encircling over here. These balls of connective tissue that you find in the alveolar spaces are going to be given an important name. They are called by the name of Mason bodies. So, a usual one-liner question that it need to be aware of is going to be a fact that Mason body is a finding associated with cryptogenic organizing pneumonia, and I repeat that that's simply the presence of a connective tissue ball which is present in the alveolar space. As you can be recalling from the discussion in the main videos, so far as a cryptogenic organizing pneumonia is concerned, in this kind of a condition, we are not going to be having the presence of something like a honeycombing of the lung. So that is what I wanted to be aware of, the Mason bodies in cryptogenic organizing pneumonia. The next important example of restrictive lung disorders are the one which are going to be professional hazards. So these are the conditions that are going to be given the name of pneumoconiosis. Now, if anybody was to ask you about a simple fact, the commonest pneumoconic disorder in the world, you would be very confidently answering that as by the name of silicosis. The pneumoconic disorders do result from the inhalation of fine dust particles between the range of 1 to 5 microns, which are responsible for causing a stimulation of the alveolar macrophages, thereby causing release of certain factors, proliferation of the fibroblastic tissue, and therefore going to be contributing to the development of restrictive lung disease. When we talk about silicosis, just about 4 points that I want you to remember. This is an example of a light dust particle, so it causes predominantly an involvement of upper lobe of the lung. Fact number 1. Fact number 2, silicosis has been associated with a higher risk for development of tuberculosis as well. So this is associated with the term silicotuberculosis. Fact number 3, whenever we're going to be talking about silicosis, one of the important radiographic findings or the chest x-ray findings of these patients, which I did show you, is the presence of what is going to be given the name of egg-shell calcification. Egg-shell calcification. And fact number 4, what we need to be familiar with over here is that silica crystals are going to be showing you the presence of a positive birefringence at their deposition in the pulmonary tissue. So that is going to be the commonest pneumoconiotic disorder so far as the Indian country, that is the developing countries, as well as the Western world is concerned. We need to be familiar with the next important example of a pneumoconiotic disorder, which you can observe quite clearly over here. This is associated with a complete black lung appearance, and obviously that is something that you would associate with exposure to coal dust. So if there is going to be a mild exposure, that is going to be associated with the term anthracosis. Anthracosis therefore associated with the term that the affected individual is going to be having what is termed as a black lung. There could be a situation in which anthracosis is going to be prolonged. That means there is a prolonged coal dust exposure which is going to be associated with development of simple coal workers pneumoconiosis. And if there is a chronic exposure, after many years, individuals can be having a development of what is going to be given the name of progressive massive fibrosis. If there is a coexistence of rheumatoid arthritis plus there is going to be existence of coal workers pneumoconiosis, that is what is supposed to be remembered and answered confidently in the exam by the name of Kaplan syndrome. So we need to be familiar with this particular fact so far as anthracosis or exposure to the coal dust is concerned. The next important example of an important disorder in the pneumoconiotic category is because of exposure to asbestos. Usually in the recent time, the trend has been that every alternate paper would be containing at least one question from the exposure to asbestos. Recall from a discussion that asbestos can be associated with construction. That means it can be seen in individual who has been exposed in the mines. It can be seen in individuals who are going to be working in the insulation, whether that be a fire insulation or whether that be a waterproofing material which is being used commonly. This condition is going to be associated with the initial manifestation in the form of development of a pleural plaque. What is also going to be then observed in these patients is going to be the development of interstitial fibrosis, and you are going to be having the presence of this kind of a structure which is going to be the bead-like appearance, which is going to be having this appearance, and that is what is being given the name of an asbestos body. So dumbbell-shaped appearance that is going to be seen in the pulmonary tissue associated with the term asbestos body. The problem with the exposure to asbestos lies in the fact that this is an example of a chemical which can possibly cause a mutation, and it also enhances the proliferation rate of the mutated cells. So as you can recall from our discussion in neoplasia, it is both an example of a initiator as well as promoter chemical. It is therefore associated with an increased risk of development of multiple types of cancers: laryngeal carcinoma, anal carcinoma, renal cell carcinoma, bronchogenic carcinoma, as well as malignant mesothelioma, all those cancers associated with asbestos exposure. The commonest so far as the lung cancer is concerned due to asbestos exposure happens to be bronchogenic carcinoma, and the most specific lung cancer which is seen because of asbestos exposure should be answered in the exam as a malignant mesothelioma. Of course, we are going to be talking about the variant of bronchogenic carcinoma seen because of asbestos exposure, that is going to be adenocarcinoma, and how do we distinguish it from the malignant mesothelioma in the subsequent discussion. As of now, all I want you to remember over here is the importance of asbestos inhalation in the form of development of pleural plaque, interstitial fibrosis, asbestos body, and a high risk for development of different types of cancers in the body. The next important example of a condition is going to be an infectious condition, perhaps beyond which no particular paper in the Indian context could ever be complete, and that is going to be pulmonary tuberculosis. So when you talk about pulmonary tuberculosis, the causative organism, that is Mycobacterium tuberculosis, enters inside the lung because of point number 1, droplet infection. This causes the formation of a subpleural lesion when we talk about the term primary pulmonary tuberculosis, and that is likely to be associated with the appearance of this sort. So subpleural focus, that is what I want you to remember, which is going to be given the other important name of Ghon's focus. Ghon's focus, along with the involvement of the localized lymphatics and the lymph nodes, is going to be associated with the term the Ghon's complex. Whenever there is going to be a calcification in the Ghon's complex, that is going to be associated with the term the Ranke's complex. There is a possibility that if the immunity of an individual is going to be working fine, which usually takes place after about 3 weeks of exposure, this is likely to be associated with inactivation of the bacilli. During subsequent years, when there is a reactivation of the bacillus, this is going to be associated with development of secondary pulmonary tuberculosis. So watch out for the question in the exam carefully. Commonest reason for primary pulmonary tuberculosis is droplet infection. Commonest reason for development of secondary pulmonary tuberculosis is reactivation of a latent infection. Whenever we are talking about a latent infection, if an individual is having immunosuppression, the bacilli can go and cause seeding of different areas in the body, and if there is a systemic involvement, that is given the name of miliary tuberculosis. Please recall from our discussion between primary and secondary tuberculosis, we find that hilar lymphadenopathy is more likely to be seen in case of primary pulmonary tuberculosis. features like cavity formation are more likely to be seen in association with secondary pulmonary tuberculosis. At a microscopic level, the bacilli is an example of an acid-fast bacilli which can be seen quite comfortably in the sputum when we are looking at it with the help of a Zeal-Nielsen stain. Of course, if the bacillary load is going to be less, a microbiology link, we are going to be using a method which is going to be given the name of the Petroff's method for the sputum concentration. When we have the seeding of the bacilli in different areas of the lung, you are going to be having the presence of those millet-like, the white dot-like appearance in different areas of the lungs as well as different organs as you can find over here. So that is what is going to be given the name of miliary tuberculosis. Miliary tuberculosis. We need to be familiar with the fact that at a histological level, the tubercular infection is going to be characterized by the presence of a granulomatous inflammation. So that is what is going to be showing you the presence of a granuloma formation. That is going to be an example of, and if you can appreciate over an example of a giant cell as well. And a better picture I would suggest you to have a look at over here is going to be, this is going to be a granuloma. So granulomatous inflammation suggestive of a chronic inflammatory pattern that is associated with tuberculosis. Of course, that's a kind of a giant cell that you see in case of tuberculosis, which is going to be given the name of, and that's easy one, that's going to be given the name of a Langerhans giant cell. Langerhans giant cell, the one that you are going to be having in association with something like pulmonary tuberculosis. Of course, nowadays we do have the availability of something like the nucleic acid amplification test, which can confirm the presence of a tubercular infection. But nonetheless, usually we rely on, in the peripheral parts of our country, something like the sputum examination, early morning sputum sample, and MMR, that is a mass miniature radiography, for having a confirmation of the diagnosis. Looking at the next important image, this is an image which is going to be showing you the presence of a big clot which is present in the pulmonary vasculature. So what I am showing you as of now over here is an example of a condition that is going to be given the name of the pulmonary thromboembolism. Now, the moment we are going to be talking about something like a pulmonary thromboembolism, this is going to be an example of a condition that is going to be characterized by the formation of a clot. This kind of a clot is going to be traveling all the way from the systemic circulation into the lungs. The original place, the place where the clot is actually going to be originating in 95% of the individual happens to be the venous system, the veins of the lower limb. Now, in majority of the individuals, the clot usually is going to be pretty small, and therefore this kind of a clot is likely to remain silent. So that is another question that they put up to you in the exam, that majority of the pulmonary thromboemboli are going to be silent. However, if there is going to be a regular phenomena, or if the clot happens to be a large clot, then definitely that is going to be responsible for causing the development of clinical manifestations. What can also be seen in an individual having pulmonary thromboembolism is that this can contribute to the development of a sudden strain, and that is going to be associated with important findings that you see in the ECG. Along with that, there can be a situation when the individual can suddenly die as well. Pulmonary thromboembolism is an example of a condition in which you are going to be having an elevated value of D-dimer. So, of course, there can be a lot of other conditions where the D-dimer value can be elevated, but two conditions which are very high for your exams. One, DIC, that is disseminated intravascular coagulation, and the second is pulmonary thromboembolism. Two conditions where the D-dimer values are going to be really high. So, at least that much of information that we need to be remembering so far as this particular image is concerned. They have earlier given in your exam an example of an image in which the clot was having an entry into the two important branches of the pulmonary artery. That kind of a clot which is going to be having an appearance. Say for example, the clot is having this kind of an appearance. So, in an image which is going to be given in your textbook as well, this is going to be given the name of a saddle embolus. So, at the bifurcation, if there is going to be a clot and that is having a tendency to enter into both the branches, that is what is given the name of a saddle embolus. So, that is what we need to have an idea so far as a pulmonary thromboembolism is concerned. The next important example of an image which is a very high image from the exam perspective is going to be given the name of amniotic fluid embolism. Amniotic fluid embolism question in the exam will typically be talking about an example of a situation in which because of the rupture of the membrane, there was a leakage of the amniotic fluid into the systemic circulation. Now, when the amniotic fluid is going to enter into the systemic circulation, it will bring with it the presence of the fetus squamous, that is the fetus epithelial cells and the other tissues, and that is what is going to get deposited inside the pulmonary vasculature. So, this is going to be the picture that you find. So, what you find over here is the presence of the fetal tissue right up over there, which is going to be causing an obstruction and a problem at the level of the pulmonary vasculature. So, that condition is what is going to be given the name of amniotic fluid embolism. Two things that you need to remember. Amniotic fluid embolism is going to result in a catastrophic, it is going to result in sudden onset of dyspnea and trouble in a patient who has just delivered. Usually, it is not going to be seen. So, it is not an example of a very commonly observed condition. But the unfortunate point is that in case it so happens, then this is going to be associated with a relatively high degree of mortality in the affected individuals. The next important example of embolism that we need to have an idea for sure happens to be fat embolism. The classical picture in the exam can be of two important subtypes. Fact number one, there's a guy who has just met up with a road traffic accident, and that is responsible for causing a fracture at the level of the long bones. Situation number two could be a situation wherein there is a guy who has been recently operated by an orthopedic surgeon. Say for example, they are fixing up the hip joint or they are fixing up the femur for some reason, and that is responsible for causing the leakage of the free fatty acids into the systemic circulation. So that is what is going to be associated with the fat bubbles going to travel all the way from the systemic circulation into the pulmonary vasculature, which you can be appreciating over here. So history becomes a very, very crucial thing. The other thing that you need to remember so far as a fat embolism is concerned is going to be the fact that these patients are going to be having a trouble, that is going to be a decreased level of oxygen so far as the blood is concerned. So that is what is going to be given the name of hypoxemia. Fact number two, the patients are going to be having CNS manifestations or neurological manifestations in the form of development of dizziness, altered sensorium, or the presence of a confusion. And fact number three that the patients are going to be having is presence of pulmonary dermatological manifestations in the form of development of petechial rash. So hypoxemia plus CNS manifestations plus skin manifestations in the form of petechial rash, that's a classical triad that you associate with fat embolism. Of course, so far as we need to make a diagnosis for this condition, so another important question that they ask in the exam is the name of a criteria that is going to be given the name of the GERD criteria. At a microscopic level, how would you distinguish the fat embolism? One very important finding is the clinical history, which is going to result in this kind of a classical triad manifestations. The second fact is fat is going to get washed off when you're preparing the slide. So those globules, the empty areas that you're going to be finding inside the vasculature is very much suggestive of something like fat embolism. So this is what you need to keep in mind so far as fat embolism is concerned. Talking about the next question, that is going to be given the name of vegetable aspiration pneumonia. Classically, you are going to be given a history in which an individual happens to be in an inebriated state. So that means that because of whatever reason, there is going to be a depressed gag reflex. Let's say if an individual has consumed a lot of alcohol, and this is going to be associated with aspiration of a food material that he is eating. So let us say he has aspirated the vegetable. Now because he has aspirated the vegetable, that is going to be going inside the lungs, and that is going to be manifesting itself in the form of this kind of a refractile material. So history becomes very, very important that an individual is in an inebriated state, suppressed gag reflex, aspiration of a food content, something like a vegetable, and the presence of a refractile material, which is suggestive of the fact that there is some kind of a foreign body or a non-living object that is present in the pulmonary tissue. So that is what is associated with something like a vegetable aspiration condition. Something that was asked in one of the AIIMS exams. So just I thought it would be good enough for you to have an idea at this kind of a picture. The next important example of an image that we need to have an idea is what is going to be associated with development of a condition which is going to be given the name of pulmonary hypertension. Now pulmonary hypertension is a term that you would be using only in a situation wherein the pulmonary pressure is going to be becoming almost 1/4 of the pressure in the systemic circulation. Please recall the fact that this could be an example of a primary condition or this could be an example of a secondary condition. So what the examiners have already asked you earlier is that one of the important reasons for development of the primary pulmonary hypertension is because of involvement of a gene which is going to be altering the activity of the bone morphogenic protein receptor gene. So it is not the bone morphogenic protein, it is a bone morphogenic protein receptor gene which is going to be having an alteration. You see, the normal gene is responsible for reducing the proliferation of the fibroblasts. But if there is going to be a gene mutation, the inhibitory effect goes, and that is going to be associated with increased formation of the fibroblastic tissue. Additionally, there can be situations when the individual is going to be suffering from, let us say, obstructive sleep apnea, or there could be an individual who is going to be suffering from recurrent attacks of pulmonary thromboembolism, or you could be having a situation in which an individual is going to be suffering from left ventricular failure. So all of them can be responsible for causing development of pulmonary hypertension. Now what exactly is going to be the typical finding of pulmonary hypertension? This is going to be characterized by the fact, point number one, that there is going to be too much of a smooth muscle hypertrophy. So smooth muscle hypertrophy is going to be one important component. Fact number two, the capillaries are going to be showing you the presence of a fibrointimal thickening. So smooth muscle hypertrophy and the capillaries are going to be showing you fibrointimal thickening, that is what is going to be associated with the term plexiform lesions. Plexiform lesions. So in the stem of the question in the exam, the moment you hear those terms, plexiform lesions, smooth muscle hypertrophy, especially secondary to a condition like obstructive sleep apnea or a condition like maybe recurrent pulmonary thromboembolism, that should immediately alert you to the fact that an individual is going to be suffering from a condition like pulmonary hypertension. Why do we need to be familiar with this condition? Is obviously because of the fact pulmonary hypertension can contribute to the development of right-sided cardiac failure. That is what is going to be given the name of cor pulmonale. And as I discussed just few minutes back, just to help you revise that, one of the important conditions in which cor pulmonale can be causing mortality in the patients is going to be something like the chronic obstructive pulmonary disease. Therefore, I explained to you that these individuals are going to be having a decrease in their mortality by the administration of oxygen. Of course, so far as the management of routine pulmonary hypertension is concerned, you can be using drugs which are going to be something like either the nitric oxide or the vasodilators in the form of something like the endothelin receptor antagonist. I hope you can remember from your knowledge of pharmacology, drugs like bosentan, emrisentan. That is what we need to have an idea so far as pulmonary hypertension is concerned. Looking at the next important image, the exam question would be talking about an example of a condition in which the individual is going to be suffering from some kind of a lung tumor. And if you have to talk about the commonest lung tumor that they typically love to give you in the exam, that is going to be something like bronchogenic carcinoma. The moment we talk about bronchogenic carcinoma, of course, we understand the fact that one of the commonest variants of bronchogenic carcinoma that is going to be associated with smoking happens to be what is going to be given the name of what is appearing on the screen as of now. That's going to be something like the squamous cell carcinoma. So when we talk about squamous cell carcinoma, yes, it is going to be having a definitive association with something like a prolonged history of smoking. We need to understand the fact that it is an example of a tumor which is going to be central in location, so near the hilum. It is associated with the fact it is going to be having the presence of a cavity formation. And we need to be familiar with the fact that this is an example of a tumor which is going to be having the presence of the hyperchromatic squamous cells, which are also going to be having the presence of this kind of a structure which is given the name of a keratin pearl. When we are talking about the squamous cell carcinoma, we need to be reminding ourselves of the fact that yes, you are going to be having molecular markers that we talked about. So one marker can be something like keratin. Of course, we can be having markers like P63 over there, which can be confirming the presence of a squamous origin of this kind of a cancer. Let us not forget the fact that as and when you are looking at a squamous cell carcinoma, of course, this is going to be the presence of the tumor cells and this is going to be the presence of the keratin pearls. At the higher magnification, you can even see the presence of the keratin bridges, which I've shown you in my book as well. When we are talking about the squamous cell variant of the bronchogenic carcinoma, please understand the fact that this particular variant is going to be associated with a peculiar paraneoplastic syndrome, and that is the development of hypercalcemia in the individuals. Looking at the next important variant of bronchogenic carcinoma, which the examiners can possibly ask you, the complete slide is going to be having a bluish appearance because of presence of cells which are small in size but which are going to be having the presence of hyperchromatic nuclear material. And better image of this would be something like the cells that you can appreciate over here. So these cells which are going to be much dark so far as the nuclear material is concerned. Now when we are looking at something like the small cell variant of the bronchogenic carcinoma, you need to understand the fact this is going to be having the strongest association with smoking. The fact that this is going to be an example of a small cell cancer will remind you of the fact that this particular cancer is going to be highly aggressive in nature and therefore it is notorious for having the presence of CNS metastasis. In spite of the fact that this particular variant of the bronchogenic carcinoma is going to be the most chemosensitive and the most radiosensitive, you still need to remember the fact because of its micrometastasis aggressive nature, it is going to be having the poorest prognosis. The small cell over here would remind you of the fact that there is no presence of neurosecretory granules over here, and therefore what you find in this kind of a variant of the bronchogenic carcinoma, this would be having the presence of the maximum amount or number of paraneoplastic syndromes. Some of the important ones which the examiners love to go after, SIADH, because of excessive secretion of the antidiuretic hormone. Another one that you need to have an idea is because of the excessive secretion of something like the ACTH, which is going to be responsible for causing development of Cushing syndrome. When we are talking about the small cell variant of the bronchogenic carcinoma, we need to remind ourselves of the fact, as I discussed with you earlier as well, there is going to be an overexpression of something like the BCL2 over here. Another important peculiar finding which I have not shown you over here is that sometimes the nuclear material can leak out from the tumor cells over here and they can cause the staining of the vessel wall. So that particular staining of the vessel wall is what is going to be associated with the term that is what is being given the name of the Azopardi effect. So you need to be familiar with all those terms. All those are going to be one-liner questions or applied questions that the examiner can give you pertaining to the small cell bronchogenic carcinoma. The next important example of a condition about which we need to have an idea is what is going to be given the name of adenocarcinoma in situ. As I explained you in the main video section in detail quite clearly, that as and when we are using the term in situ, that means that there is no involvement of the or breaching of the basement membrane per se. So what you find over here is that the dysplastic cells are going to be growing along the alveolar septa or along the time to pneumocytes, and they are not going to be causing a breach of the basement membrane. Therefore, they are going to be having what is being termed as the lipidic pattern. I do expect a lot of you to have gone through the main videos wherein I did explain to you in detail about the presence of the atypical adenomatous hyperplasia. We did talk about something like adenocarcinoma in situ, which was earlier being given the name of the bronchiolo-alveolar carcinoma. So one of the important reasons why the examiners love to ask you a question on the adenocarcinoma in situ is that these kind of dysplastic cells can move from one lung to the opposite lung only and only through the airways without causing involvement of the lymphatics and the blood vessels. So this is going to be given the name of the aerogenous spread. The aerogenous spread of the dysplastic cells. I do hope most of you would be able to recall the fact that atypical adenomatous hyperplasia, which was less than 5 millimeters in size, and this one which is going to be less than 3 centimeters in size, can over a period progress to something like the adenocarcinoma. Similarly, we are going to be having the presence of precursor lesions in case of the squamous cell variant of the bronchogenic carcinoma. But please remember the fact that we do not have any particular precursor lesion so far as the small cell variant, which we just talked about few minutes back, is concerned. Also, another important example of a new entity which was discovered and talked about in the latest classification as per the WHO was DIPNE, in which I explained you about the presence of the diffuse idiopathic pulmonary neuroendocrine hyperplasia. So that is what I wanted to be familiar with so far as adenocarcinoma in situ is concerned. Now talking about the next important variant in which you are actually going to be having a deposition of the tumor cells, or the infiltration is a better word I would use, of the tumor cells which are responsible for forming a gland-like pattern as well as causing a breach of the basement membrane. That is what is going to be given the name of adenocarcinoma. Adenocarcinoma becomes significant in these days all the more because of the simple fact that this happens to be now the commonest lung cancer variant which is seen both in the Western world as well as in the Indian subcontinent. So both for the developing countries as well as for the developed countries, the commonest subtype of lung cancer now is to be answered in the exam as adenocarcinoma. The moment we talk about adenocarcinoma, we understand the fact that there is going to be presence of the gland forming tumor cells, and therefore they are going to be associated with an important fact that they are going to be much more commonly seen in case of females in comparison to males, usually can be seen in more commonly in case of non-smokers, and we need to understand the fact because this particular variant is associated with mucin secretion, so is going to be associated with the development of migratory thrombophlebitis. For those of you who have watched the main videos of neoplasia, in which I constantly told you and reminded you time and again, and I would still request you to do the same, the ways by which we differentiate fact number 1, carcinoma of unknown primary using CK7 and CK20, and fact number 2, the table in which I did explain you all the novel markers for making a diagnosis of different subtypes of cancers. Please go out and have a look at it in case you still haven't. I would like you to be aware of the fact that the new markers which are available for making a diagnosis of adenocarcinoma are going to be given the name of TTF, that is the thyroid transcription factor, and we have a second important marker that is given the name of napsin. So whenever we are talking about TTF and napsin, so far as a bronchogenic carcinoma variant is concerned, you have to think in terms of something like an adenocarcinoma. Of course, we are having the presence of a special slide in which I wanted to show you the presence of TTF positivity, something which is quite similar to the one that is given in your textbook Robbins as well. So that is a discussion so far as the three main variants of the bronchogenic carcinoma is concerned. Not to be left out, but then the last variant that I just wanted to have a look at is what is going to be given the name of the large cell variant of the bronchogenic carcinoma. So the tumor cells over here, as you can understand, are going to be much bigger in size. Now this particular variant of the bronchogenic carcinoma is associated with the peculiar finding that this is going to be associated with the secretion of estrogen-like hormone, and therefore one of the important paraneoplastic syndromes that we get over here is the presence of gynecomastia. The next important example of a tumor that we need to have an idea is what is going to be given the name of mesothelioma. As and when we are talking about mesothelioma, we just need to be familiar with the fact that the important risk factor for development of mesothelioma is the exposure to something like asbestos. We also need to be familiar with the fact that when we are talking about mesothelioma, it is going to be having a peculiar important manifestation in which you would have the appearance of the lungs they appear to be totally encased. I mean, see the thickening at the level of the pleural surfaces. So much of thickening, it appears as if the lungs are totally covered by the thick pleura. Please be familiar with the fact, whenever we are making a mention of mesothelioma, mesothelioma is going to be having two important variants. One is going to be the benign variant and the second is a malignant variant. It is important for us to distinguish between the benign variant and the malignant variant for two reasons. Fact number one, asbestos exposure is associated only with the malignant variant of mesothelioma. It is not associated with the benign variant. Fact number two, whenever we are going to be talking about the malignant variant is also going to be having keratin positivity. Whereas keratin positivity is not going to be seen in association with the benign mesothelioma. However, I must tell you for information for your recall that benign mesothelioma is going to be having the positivity for something like CD34. Now, what is important for us to understand over here is that asbestos exposure is also associated with a higher risk for development of a particular subtype of bronchogenic carcinoma, which I did make a mention of with you earlier as well, which is given the name of adenocarcinoma. Examiners love to ask you this question time and again, particularly the examiners who are going to be asking questions on the INI-SET. And the INI-SET questions these days have a trend of being asked in the subsequent NEET PG or for that matter in the next exam as well, wherein they can ask you about the differentiation feature between adenocarcinoma and malignant mesothelioma. So you need to understand the fact that in case of malignant mesothelioma at an electron microscopic level, you're going to be having the presence of thin, long, slender microvilli. Microvilli are going to be thin, long, slender. Whereas in case of adenocarcinoma, they are going to be shorter. So I always told you, whenever you write it A for adenocarcinoma, you write it like this. Whenever you write M, you make it like this. So long, slender and thin branching out microvilli are going to be seen as a finding that you have for something like malignant mesothelioma. Whereas for adenocarcinoma, there is going to be presence of short microvilli. Examiners, since they have already asked you this question, can go a step further and talk about the markers by which you distinguish between both of them. So as and when we are making a mention of something like adenocarcinoma, I want you to be familiar with the fact that adenocarcinoma is going to be having a positivity of a marker which is given the name of MOC31. Whereas when we are talking about malignant mesothelioma, this is not going to be having the expression of MOC31. So any which way, the examiner is asking a question, whether he's talking about a question on microvilli, the special subtype, or he's asking a question on the marker, you should be confident enough to answer that particular question in the exam. Talking about an example of an infectious condition about which no discussion so far as pulmonary images are concerned can ever be complete, that would be something like the exudative solidification, which is going to be given the name of pneumonia. The first important example of an image that I wish you to be familiar with is what is going to be given the name of a typical pneumonia. Typical pneumonia is caused because of bacterial infection. So you can be having the infection caused by Streptococcus pneumoniae in a community setting, or for that matter a Staphylococcus or a Pseudomonas infection in context of a hospital acquired pneumonia. But this condition is going to be characterized by the fact that if you're going to be looking at the alveoli are going to be full up of so many neutrophils. I mean, presence of alveolar exudate plus there is presence of neutrophilic infiltration. That is going to be characteristic feature that you associate with something like a typical pneumonia. Of course, I can help you remember and recall the presence of the different stages of pneumonia, in which we talk about something like congestion, we talk about the red hepatization, the gray hepatization, and finally the resolution taking place in the time spans of 1 to 2 days, 3 to 5 days, 5 to 7 days, so on and so forth. But when we are talking about something like a typical pneumonia, you need to understand the fact that infected individual is going to be having alveolar exudate plus neutrophilic infiltration. Typical pneumonias are going to be characterized by the fact that there is going to be presence of a high grade fever along with presence of productive cough, which is going to be seen in these individuals. In complete contrast, when you are talking about the presence of atypical pneumonia, what is also being referred by the name of walking pneumonia, because a guy can actually come down walking in your clinic because he has got low grade fever. This is a finding that you expect to find in context of the atypical pneumonia. So atypical pneumonia is going to be caused primarily because of the infection caused because of an organism, something like Mycoplasma pneumoniae. Other organisms can include Chlamydia pneumoniae, or there can be infection caused by fungi, and there can be infection caused by organisms like Legionella as well. But when we are talking about something like atypical pneumonia, what we need to understand over here is fact number one, that there is going to be the absence of alveolar exudate. So there is no alveolar exudate, rather you find that the inflammatory cells are going to be present in the interstitial tissue. So there is the hallmark feature which is interstitial tissue inflammation. Fact number 2, the type of the inflammatory cells that you have over here characteristically are going to be lymphocytes. So in case of typical pneumonia, you are having alveolar exudate, you are having neutrophilic infiltration. In case of atypical pneumonia or walking pneumonia, you are going to be having the presence of interstitial tissue inflammation as well as you are going to be having the presence of lymphocytic infiltration. Of course, the organisms are supposed to be remembered so as to crack the questions in the exam. So that is what we need to be familiar with so far as the summary of atypical pneumonia and the typical pneumonia is concerned. That is in fact going to take care of the discussion of the most important images pertaining to the topic of respiratory system.